Okay, good morning. My name is Norberto Castano. Thank you very much for everybody to joining us at ACTA today. Today we have a very special guest, is Dr. Norberto Zapata. He's in this moment from Abu Dhabi. It's very far away from us, really. He joined us before. He was working like a thoracic surgeon in Saudi Arabia 5 years, and now it's at Mayo Clinic at Abu Dhabi. This week he have this new joining. Congratulations, doctor, for that.
Thank you.
He works in lung transplant program and VATS and Uniportal VATS also, and in oncological center, and in research and development of new technologies for thoracic surgery. Thank you very much, doctor. He is going to tell us today, so he's going to show us today a very special case of a carcinoid with a difficult decision of lung sparing surgery. Thank you very much, doctor. And of course, go ahead. Our time is yours.
Thank you very much, Dr. Castaño, for your kind words and your moderation. A special thanks to my friends, Dr. Abbas and Dr. Iriarte, for setting ACTA, this amazing group of thoracic surgeons, and for giving me the opportunity to make that presentation today. So let me share the presentation. Yeah. Okay, can you see the presentation now?
Yes, doctor. Okay.
That's perfect. Thank you very much. So this is the disclosure. Let me see. It's gone. Yeah, this is the disclosure of my presentation. And today we're going to talk about really a challenging case. I think it's one of my favorite cases because, you know, it's a challenge due to the management and the technical aspect of the case. So as you all know, uniportal VATS lung segmentectomy are technically challenging due to the anatomical variations, because it's technically more complex than the lobectomy, and a detailed comprehension of the segmental anatomy is required to avoid compromising the viability of the remaining segments. For sure, a long experience and strong skills are needed to perform uniportal VATS lung segmentectomies. So segmentectomy for carcinoid tumor could be really challenging many times due to the central location of this kind of tumor and the tumor size. Synchronous bilateral centrally located carcinoid tumors are extremely rare and really challenging to manage, and this is the case that we will discuss today. But when feasible, the segmentectomy is helpful as a lung-sparing technique to preserve as much as we can the lung and pulmonary function. So the case report is a 32-year-old male non-smoker patient having asthma and moderate severe asthma inhalers with GERD. The patient was having chest pain and progressive hemoptysis and shortness of breath for the last 2 years when he came to our clinic. So we move forward with the CT chest, and in the CT chest we saw in the right side is the you can see here is nodule centrally located in the segment of the right lower lobe, and the left side was almost 3 centimeter tumor affecting the airway and in the lower lobe, just reaching the secondary carina between the upper lobe and the lower lobe. So the picture was worrisome for carcinoid tumor due to the patient age and the comorbidity. So we decided to request a gadolinium PET scan that show, as you can see here in the picture, uptake in both nodules, confirming the patient was having a bilateral synchronous carcinoid tumor. The pulmonary function test was pretty good despite the patient was having a severe asthma, but was showing a really affection of the small airway. So we have to deal with the asthma before moving forward with the surgery. Sorry?
Before you continue, just for making some kind of discussion between all of us,
Sure.
In this moment, we don't have any diagnosis, it's a pathological diagnosis of carcinoid, right?
Exactly. Based on the gadolinium PET scan, is confirming that the patient is having bilateral carcinoid tumor. So bad, we decided to do bronchoscopy to assess the airway and take biopsy as well.
Okay, but it's maybe a good moment to ask if there's any other options of a carcinoid tumor, principally thinking that it's two of them at different places, centrally located tumors. Maybe Dr. Einer could tell us what do you think there's another one, another type of histology, another type of cancer can give us this kind of image.
Good.
Dr. Einer is there. Or maybe Dr. Garcia Herreros.
What's your question, Wilfredi? I didn't understand.
If you have that CT scan, you always think in the carcinoid tumor because it's double places. So it's, of course, yeah, it can be a carcinoid tumor, but there are two places different at the same time. Is there another option that is offered there? And of course, you have a PET CT scan that is really, really positive. Maybe you have another option of tumor, different of carcinoid.
No, I think exactly like Norbert is. I think that with that gadolinium PET scan, the diagnosis is very clear, and it's not frequent, but I've seen couple cases of synchronic carcinoid tumors in young people. So I would be quite safe with that diagnosis.
Okay, but what about a epidermoid cancer? Do you think it's possible?
It could be possible. Could be possible, but the image, the CT scan and the image of the gadolinium PET is, for me, is very confirmatory of the diagnosis.
So with those CT scan, you made your decision of what kind of PET CT scan are you going to ask? Because it's different, the kind of PET scan you're going to do. For looking for a carcinoid, not?
Yes, but I don't know. I think that for me is clear.
Okay, thank you very much, Dr. Liz. In this moment, anyone else have a different opinion about this kind of tumor? It can be another thing, or maybe a different image can be asked for. Okay, thank you. Dr. Norberto, please continue, please. Thank you very much.
Thank you very much for the discussion. So then, due to the central location of both tumor, we decided to do a bronchoscopy to assess the airway and find out if it's possible to do any kind of bronchial sleeve or segmentectomy or even lobectomy. And we found the intrabronchial tumor was in the right segment 7, and also we saw intrabronchial tumor in the left segment 6. We took biopsy and it was confirming that the patient was having carcinoid tumor, as the gadolinium PET scan showed. So the next step was just to move forward with the surgery, and the surgery planning was extremely challenging. So we're talking about a very young patient with moderate severe asthma, with 2 bilateral synchronous carcinoid tumor affecting both lower lung. So what should do it? Bilateral lower lobectomy in a patient with that conditions sounds not really good. So we thought it's possible to do lobectomy in the worst scenario, and segmentectomy is possible to do 2 segmentectomies in the right and the left side. So initially we planned the surgery for bilateral segmentectomy. We started with the left side, but unfortunately the tumor in the left side was reaching the secondary canal between the upper lobe and the lower lobe over the bronchus. intrabronchial, so over the bronchus. So we couldn't do segmentectomy, and we had to perform uniportal VATS, left bronchoplastic lower lobectomy, suturing the bronchial stem to get a good surgical margin. So then the second challenging surgery was what to do now with the right side, with this nodule centrally located that was reaching the always the segment, the bronchial from the segment 7. So it was really difficult to decide, but we try our best. We moved the patient to the OR and sequential. So surgery, planning the surgery for bronchoplastic segmentectomy 7 without knowing it would be feasible or not. And I will show you now the video of the surgery. So we started dissecting the major fissure. You can see the middle law upwards, the lower law downwards. We're exposing the basal pulmonary artery in the fissure. And we're dissecting a little bit more the artery to expose the branches. You can see it's now a little bit the arterial branch for the segment 7 and the lymphadenectomy that we did around the highland to get us more space to do the dissection of the arterial branch. We dissected that and we stapled the arterial branch for segment 7, A7. So then you can see below the bronchus. So we dissected the bronchus and we saw the tumor. You can see the tumor there very next to the bifurcation between B7 and B8 and B8 to B10. So we decided to do the bronchoplastic procedure, opening the airway at the level of the proximal stump of the B7 to get free margin. So now you can see the vein. You see the airway now, the stump, B7 stump, the remaining airway, and the small venous branch for segment 7 that was divided. And it was, I think, the most difficult point of the surgery, how to close the small hole of the stump. And we use this cross suture going from upwards to downwards and then crossing the suture with the PDS, 4-0 PDS, and it was enough to suture the bronchial stump. Sorry for the quality of the image here, but we were having some technical difficulties. So we knot the sutures and we proceed now with the intersegmental plane division. So we extending a little bit more the intersegmental plane to a little bit to the segment 8 because the tumor was more than 2.3 centimeter to make sure that we get a free margin. The segmentectomy was completed. We usually fill in the highland with some T-cell, and you can see the lung was completely reinflated, and you see the basal segment so are now going up. So this is the approach, the uniportal approach. Was a 3 centimeter approach. I think a little bit less than 3 centimeter. It was a very small approach. The patient was having a the patient was having a very good postoperative outcome. The operative time was 91 minutes. The estimated blood loss was really low, was 100 milliliters. And the average range was 1.6 plus minus 1.43 in the EVA scale. So you can see the postoperative chest X-ray here without chest tube because the patient was discharged at the first postoperative day, having a good outcome. And you can see here the pathology. The pathology confirmed that the patient was having a typical carcinoid tumor in the right side, but curiously, in the left side was showing an atypical carcinoid tumor. So I think it's the first case in the literature, and we plan to report it. It's very rare to find two synchronous bilateral carcinoid tumor, one typical and another one atypical. So the size was 2.3 centimeter, as you can see here. the bronchial margin was uninvolved by the tumor. We got almost 1 centimeter of free margin, and the intersegmental plane divided was involved by the tumor as well. As you can see, the Chesser ray. So this is the left side where we perform the left uniportal left bronchoplastic lobectomy. The upper lobe is completely fully expanded, occupying the whole cavity, and this is the segmentectomy on the right side. So the patient is after 3-year follow-up. The patient didn't show any recurrence, so we are really happy with the results. Neither in the left side nor in the right side, no recurrence after 3-year follow-up for this kind of very rare case. And we can conclude that uniportal VATS right bronchoplastic segmentectomy 7 is an unconventional approach to prevent lobectomy. We cannot say this the conventional segmentectomy is an unconventional segmentectomy, but it's safe and feasible lung-sparing technique in patients with synchronous bilateral carcinoid tumor to prevent the bilateral lower lobectomy. That could be a procedure that can affect the lung function overall in patients with this kind of asthma conditions. It provided the patient with a short length hospital stay, low pain as you saw in the outcome, and a long disease-free interval. Thank you very much.
Thank you very much, Dr. Norberto. It's a great case. I have some real questions for you and for everybody to kind of make a little discussion. I remember always when I was in the moment when I was studying thoracic surgery 12 years ago, there was some kind of notion of order when you do the surgeries if you have both sides, left side and right side. As I think I hear you did before the left side, and after that you go to the right side. What do you think that chance?
Yeah, we started with the left side because the tumor was bigger in the left side. So we were having some fears about the lobectomy. So we thought, let's try to start with the bigger tumor and see if we are able to do segmentectomy or lobectomy. So that's why we will have a better idea that what would be the next step for the contralateral side. That's why it was more challenging, because we couldn't do segmentectomy in the left side. We didn't want to proceed with the double lower lobectomy. So that's why it was more challenging to do the segmentectomy 7 and extend the segmentectomy to the bronchoplastic procedure.
Thank you very much, doctor. Another thing, anybody in the auditorium maybe do fresh evaluation, histopathologic evaluation of the margins inside surgery to decide if you're going ahead far from the resection, maybe? Like a fresh frozen evaluation?
I think that, I mean, if you
could you repeat the answer, please?
The question is, does anybody here, when you have those carcinoid tumors or near carcinoid tumors that are just in the line of the section, maybe you do fresh frozen section analysis by pathology inside surgery to decide if you go further away in the resection, or you have to make maybe a bronchial resection with Mariana anastomosis for the lower lung lobe? Dr. Norberto made maybe fresh frozen section analysis of the bronchial margins.
I think that if you're having doubts and macroscopically you think you are like really close to the margin, I think that you can do that. I remember doing a case with Dr. Abbas of one of these neuroendocrine tumors, and he was taking also proximal margin. So I would say that if you're having doubts, you can do that. Otherwise, if you macroscopically can see that you're, a little bit far from the margin, I think that, it's like, it's up to you then. It depends how much margin do you have to take as a proximal margin, you know?
I personally in surgery never made a bronchial section with a stapler when it's a carcinoid tumor. And I always watch by bronchoscopy inside the surgery before I'm going to take that section, because I am always afraid of getting a bronchial margin, because reintervention is not so easy and so much in a lot of times. What do you think about Dr. Norbert? I'm sorry, doctor, you're muted.
Sorry, because I lost the connection just for a while. Yeah, fully agree. So the carcinoid tumor are really challenging because it's, most of them are centrally located and you never know. So it's preferred to get a good free margin and do inspection of the airway, assess the airway well to make sure that you need any kind of bronchoplastic or bronchial sleeve procedure, because it's most important for that kind of patient to be curious to have a good surgical free margin, free surgical margin. In this case, I don't remember exactly, but it was almost 1 centimeter. I can say 0.9 or 1 centimeter of bronchial free margin, so it was pretty good.
Okay, and what do you think about making a lymphadenectomy? I'm thinking about this because principally by the left side, you have a typical carcinoid tumor. Maybe it's normal or it's have to be done. Lymphadenectomy over there of EN1 and 2 maybe, or intrapulmonary lymph node dissection. What do you think about that in this kind of tumors?
Yeah, surprisingly,
We lost the connection with Dr. Norberto.
Yeah, we lost a connection with Dr. Norberto.
Yeah. Everyone here, he's reconnecting.
I'm sorry, I'm having problem with the connection. I'm not sure what's going on. I'm so sorry. So
No problem, doctor. It's okay.
No problem, Dr. Norberto, you can go ahead.
yeah, okay. So I was saying that when I'm performing any kind of lung resection for carcinoid tumor with regard to the lymphadenectomy, I usually do local regional lymphadenectomy because you never know, and the pathology can be changed after the final diagnosis. So in the left side, we did the lymphadenectomy around the highland. When the patient was having the atypical carcinoid tumor, were all negative. Despite the gadolinium, PET scan didn't show any uptake. And the right side, I show you in the video, one of the lymph node that we were removing, all negative one. We found one around the highland and one next to the vein for the segment 7 were all negative.
That lymph node was really on 11, right?
Yes.
The one that you removed, that was in 11 one. Okay, and that was negative, of course, I think. Great. I have maybe a last question for you. I saw you discharge patient 1 day after, and there have been some discussion a long time ago about the type of suction, pleural suction can be a problem after that. Do you use pleural suction after your surgeries or not? If that does affect the time that you're going to discharge your patient, maybe?
Yeah, thank you for the question. In my practice, I can say that maybe I do the opposite that many colleagues are doing. I never connect the water switch chamber to suction, never, in the first postoperative day, because I'm convinced that the suction when the chest tube is next to the staple line can increase the air leak. So I don't like to do that. In my experience, most of my patients can be discharged on the first or the second postoperative day. Doing that technique, don't connect the chest tube or the water switch chamber to suction. And usually for segmentectomy, when I have to restrict the lump parenchyma, I learned that using the power staple and the black reload, we can minimize drastically the air leak. So many of the patients can be discharged 1 or 2 days after the surgery.
And I think for the last one, there are different techniques of seeing what is the staple line, the segmentectomy staple line. Do you use any one of those, any technique for
Yeah,
what it is?
thank you for the question. I usually use the inflation-deflation test. So sometimes showing the intersegmental plane. Sometimes when I have the technology around, and in my new hospital here, we have the ICG die is good as well. So another trick that we learned is the when you keep the lung inflated for 15 minutes or 10 minutes, no, after the bronchial division, they will show you the intersegmental plane as well, because the segment that we need to remain, no, will be inflated after the deflation. But sometimes happen that when you do that, you will have some problem with the deflation of the lung, and then to staple it's very difficult. So I prefer to use the inflation-deflation test. In this patient, we didn't do it. You know why? Because the patient was having the intrabronchial lesion, and the segment was having air trap. So if you see the video, you can see the intersegmental plane almost clear, but as the tumor was a little bit bigger, I took a little bit of the segment 8 to make sure that I wanted to have the free surgical margin I needed.
Thank you, Dr. Facundo. Do you have experience with the ICG for those intersegmental planes over there?
Yes. I mean, I train in the US. There are like almost everyone uses ICG. Here in Argentina, I haven't had the opportunity to ask for it. But as I said, where I trained with Dr. Abbas, well, Dr. Abbas, he really likes the ICG because, you know, he's mostly a robotic surgeon. So the technology allows him to use it like really, really easily. But I have met other surgeons that they don't use ICG at all. For example, Stacy Sue, who was his partner, she didn't use it. She's a VATS surgeon. You know, I think that you can do either way. I think that whatever you are more comfortable with is okay. I think that for learning points, for example, for me, that I was learning when I was training, it's really helpful to use ICG. One of the surgeons at Memorial, Dr. Park, who is a robotic surgeon, he almost never uses also, but he uses, we mark the plane that we think we're going to take, you know, in the lung parenchyma, and then he uses it just to teach, you know, and you're almost like quite right when you think you have to take some part of the parenchyma, you did all the surgery and anatomic resections, right? So I think that it depends on how comfortable are you like using it or not. But I think in most cases you can go ahead without using it.
Thank you, Facundo. Is there anybody else that used another kind of technique for watching the intersegmental plane, maybe? Can tell us another experience of that? Maybe we'll all use the same. I don't have ACG neither in this moment, so I use the deflation technique.
My only concern will be when you don't use ICG and you have a patient that don't have good pulmonary function test, and you may have some ventilation across the lobes or across the segments. How do you manage that, right?
Yeah, problem. This is the problem when you use the inflation test for 10 minutes instead of doing the inflation deflation test quickly. So the lung trap can make very uncomfortable the the identification of the intersegmental plane later on. Yeah, it's true.
Right. So maybe I think that you can reserve ICGs for those cases, maybe that you think that it may take a lot of time to deflate the lung, but I think in most cases you can go ahead without using it.
Yeah, absolutely. Most of my cases are done with the inflation deflation test. when you have speeding enough, you can identify the intersegmental plane. I can say quickly, but easily.
Right.
Okay, I want to ask you also, you ever use, or you always use, maybe the fiber glue in your segmentectomies? Because in my country, for example, it's like $1,000 more if you use that kind of product. So we have to be aware of the costs here, of course. You always use it, and if you have any maybe concerns of economical concern of that there?
Yeah, absolutely right. So it's more expensive than other kind of techniques, but you have to balance the expenses that you have in the OR with the expenses that the patient could afford being admitted to the hospital for more days. So you never know. For example, in Europe, I'm not sure in your country, but in Europe, 1 day in the ICU worth 2,500 euros. And each day at the hospital is almost 900 euros. So it means if you take into consideration that, maybe it's not so expensive to use the power staple and the blood reload if I can discharge the patient the day after the surgery.
Okay, thank you very much. That is a great answer, really.
Thank you very much.
Okay, if there's anybody else here that wants to make another kind of question of Dr. Norberto, or have any concern or something to add to the discussion, it's a really great case, doctor. Thank you very much. Because this is not a normal segmental resection, really. It's a little quite rare, really. And it was nice. It was a little. We have concerns about that because it's not normal, but it's a great case. Thank you very much, doctor, for showing us today, and for teaching us also, of course, all of these techniques. Thank you very much, doctor.
Thank you very much again for the invitation. It has been a great pleasure, and I hope to have the opportunity to meet all of you, right, in person someday.
Thank you very much, doctor, and I hope you great luck in your new work over there.
Thank you very much. Take care.
Thank you. Congratulations for your case, and good luck with your paper if you're going to make a paper with this case.
It's almost done. Thank you very much. We appreciate it.
Okay.
Thank you very much for everybody. Have a very nice day. Bye-bye. See you
Take care.
next month.